Well, good morning, everyone. It's 9:35, so maybe we can get started. Welcome back to our first rounds of I guess what will be the fall semester, even though it's still summer. We hope you had a good July and August, and thanks for being here. And in terms of announcements, we're going to pull up a description of our seminar that's coming up. Yeah, here we are. So just want to remind folks who don't know or haven't registered yet, this is next Thursday, the 15th, are put on by a biobehavioral core of the current HIV Center, moving the frontiers of PrEP research forward on axes of biology, implementation, science, and behavior. And you can see the list of speakers as maybe Stephen can scroll down. And this will be a hybrid event. So we encourage people who can attend in person to please register. It is limited in terms of how many people can be there in person. If you'd like to do that, please go ahead and register, and otherwise it will also be available on Zoom. And in terms of our upcoming grand rounds, our next grand rounds after this event will be September 22nd. And this will be one of our events where we have our former postdoc fellows who have moved on to their careers and successful careers. And we have two of our former fellows, Kate Elkington, talking about outreach strategies shown to be efficacious for reaching high-risk populations to engage them in HIV treatment and applied it to COVID. And then we have Tanya Taylor, age-friendly HIV care, preliminary results from the Department of Health, Be Into Health pilot study. So if anyone has any announcements, feel free. People can make announcements right now. Raise your hand or let Stephen know you have an announcement. Otherwise, I will introduce our speaker for today, and we're very grateful that Dr. Winnie Luseno is with us today. Dr. Winnie Luseno is a native of Kenya, now living in Raleigh, North Carolina. She's a senior research scientist at Pacific Institute for Research and Evaluation in Chapel Hill, North Carolina. She obtained her PhD in maternal and child health in 2012 from the University of North Carolina School of Global Public Health. Dr. Luseno has over 25 years of research experience and a broad background in the fields of public health, applied economics, and bioethics. Her work includes conceptualizing, planning, implementing, and evaluating federally funded projects among marginalized and underserved populations, using social and behavioral science approaches to understand health behaviors and to identify strategies to change behaviors and improve health. So she's with us today to talk about using digital tools to address stigma by promoting disclosure and social support. And welcome, and thank you so much for being here, Dr. Luseno.
Thank you so much. Let me see if I can put up my slides. So this always takes me some thinking. Let's see. If I can do this right. I think I've got it right.
Yep, looks great.
Okay. Thank you so much. Good morning to you all, and thank you so very much, Dr. Remien, for the introduction. I'd also like to thank Theo for the invitation to present to this distinguished group today. It really is such an honor and a privilege for me to have this opportunity to share with you some of my work. And I look forward to questions and comments and discussions following my presentation. So today I'm going to talk to you about a series of studies, including one that is ongoing to develop a digital intervention to mitigate the effects of by promoting disclosure and enhancing social support. The target population for the intervention are unmarried pregnant adolescents in Western Kenya. I will begin by providing context about the study region and with a little bit of a backstory of how we got here. Here being creating a digital intervention for pregnant adolescents living with HIV. I will then provide some background information about the two studies, which are an R21 and an R01, as well as present relevant findings from those studies. These two studies set the stage for the current R21, and I thought it would be helpful to talk about them first to provide a little bit of context. I will then talk about our ongoing study to develop the stigma intervention. I'll present some very early findings from the first phase of data collection and close out with an outline for the next steps of the study. So before we begin, I'd like to take a moment to acknowledge and register my profound gratitude for the investment in the form of time, effort, information shared, guidance, and funding provided by many, many individuals and institutions. Some of them are listed here on this slide. So let's begin. So this is a map of Kenya showing the 47 counties in the country. I apologize because it may not be very, may not be the sharpest image, but it suffices for the purposes of today. So all the studies I'm going to talk about are located in this region of Kenya known as the Nyanza region, that's colored here in red. The region is sometimes also referred to as the Lake Victoria region. So historically, this region has consistently had higher HIV prevalence and incidence than the national average among adults, youth, and children. And our study sites are to the north and northwest of the lake. This in blue here is the Lake Victoria. And those two are known as the Siaya and Kisumu counties. The table shows 2018 HIV prevalence data for Siaya and Kisumu counties, as well as the national rates. As you can see, the prevalence rates in Siaya and Kisumu are much higher than the national average for both men and women. Unfortunately, similar county level data are not available for young people at this time. But the most recent data that is available indicates the continued higher prevalence among young women compared to young men, which is shown in the data, in the table here. So what is available is data that shows that youth make up about 12% of the people living with HIV in Kenya. And as one might expect, the highest numbers of youth living with HIV are concentrated in counties with the highest HIV prevalence. According to the data, 55% of the youth living with HIV in Kenya reside in the 7 counties shown in the table. As you can see, Siaya and Kisumu are among those 7 counties. 2 other counties, Homa Bay and Migori, are also in the Nyanza region and are located south of Lake Victoria. 2 last things I would like to highlight about the Nyanza region, and specifically Siaya and Kisumu, are that in addition to high numbers of adolescents living with HIV, which we saw in the previous slide, the region also has high MTCT rates, mother-to-child transmission of HIV, and also high adolescent pregnancy rates compared to other regions of the country. Although here, when we look at the pregnancy rates, we see that CI and Kisumu are lower than the national rates, but when you compare to other counties, they are pretty high. So moving on, my first NIH grant, fresh out of my doctoral program, was an R21 awarded in September 2013. This was about a decade after the introduction of HIV drugs to prevent perinatal transmission, which happened in 2004. The period prior to 2004 was one of epidemic HIV infection rates and early death among infants. But around 2010, evidence began to emerge that suggested that some infected children were surviving to, I'm sorry, I keep jumping around. Some infected children survived to adolescence without medication, although they were seriously ill by the time they reached adolescent years. Some of these adolescents were out of care, either because they had never initiated care after diagnosis, or they initiated care, but eventually dropped out of care. Other studies were showing that compared to adults, youth living with HIV had poorer ART adherence and lower viral suppression rates. So additionally, reports at that time indicated that HIV stigma was widespread, and families were fearful about the effects of an HIV diagnosis on them and their children. So people were reluctant to test themselves or their children. Although the literature in this topic area was growing rapidly, there were two important gaps at that time. One was that few studies had been conducted in rural areas, and the second was that little was known about youth with different types of engagement experiences with HIV services. So we sought to address these gaps with our R21. Our recruitment strategy for the study was targeted and purposive, so that we could include different groups of adolescents living with HIV. For example, we included adolescents who were in or out of care at the time of data collection, some who had never enrolled in care. We also included adolescents who had acquired HIV perinatally and some who had acquired HIV sexually. We also had in our sample some who were pregnant and or parenting. So we conducted semi-structured interviews with a total of 32 female and male adolescents living with HIV, and they were aged 15 to 19. We also interviewed 15 caregivers, and these were parents, guardians, and spouses. And then we did 34 interviews with HIV providers. So adolescents were contacted first before their caregivers. If the adolescent gave permission for the study to invite a caregiver for a caregiver interview, then the caregiver identified by the adolescent was invited to participate. A caregiver was defined as someone whom the adolescent lived with, who knew about their diagnosis, and who took care of them. This could be a parent, a guardian, or a spouse, as indicated earlier. Adolescents could participate even if they did not want their caregiver to be interviewed. There were 9 cases where a waiver for parental consent was applied because adolescents were aged 15 to 17 and were either emancipated minors or want their caregiver to know about their research participation. So we published 2 papers using data from the study. which I have snapshotted here, and following are some of the findings presented in these two papers. So like the studies I referenced earlier, we also found experiences of stigma in our sample. Adolescents who were in boarding school described not wanting to take their drugs for fear of inadvertently disclosing their status, having to explain why they were taking drugs to their peers, and then having to deal with the ensuing gossip. They were also uncomfortable disclosing their status to teachers for fear of being treated differently, for example, being given lighter duties, which could lead, again, to inadvertent disclosure to peers and also to gossip. So when you're in boarding school in Kenya, you tend to be given duties as a boarder, and it might involve cleaning certain areas of the school, or maybe helping out in the kitchen, or whatever duties need to be done. And so those who have been identified as being unwell usually are given lighter duties. So not disclosing their status to teachers and administrative staff unfortunately sometimes resulted in missed appointments, and consequently when they would show up at the clinic for their an appointment, having missed a previous appointment, the healthcare providers would treat them harshly, for having missed an appointment. So we also had many adolescents who described not wanting to be seen at the clinic because they wanted to avoid being scrutinized by adults who were present at the clinic. We also found that supportive relationships were important for motivating adolescents to engage in HIV care. So in the next two slides, I will show examples of how youth described these supportive relationships. But first, I wanted to note that we also found differences in experiences with HIV services based on how HIV was acquired. Those who were infected perinatally described testing at younger ages. For many in this group, the motivation for testing was, in fact, their poor health. They tended to have a supportive adult present during testing and were linked to care soon after diagnosis. A number described networks of support from family, school staff, and healthcare providers. On the other hand, those who were sexually infected tested at older ages, were alone during testing, had trouble disclosing or accepting their results. They described being treated harshly by treatment providers, by healthcare providers. They did not always enroll in care and described having only one supportive person that they relied on. So these are some quotes from perinatally infected youth describing how they received support from family members. The first is from a female who was 18 years old, perinatally infected and in care. She was in boarding school, and she said, "There were times I could not leave school to come for the drugs. So I just called her," referring to her mother, "and tell her to go get drugs for me," which she always did, and bring the drugs to the school. The second was from a 16-year-old, also perinatally infected and in care. And he said, "It is them," referring to his sister and a parent, "who offer me the transport, meaning money to travel to the clinic. Now, when I am in school, my sister has offered me milk that I take daily. If I find any difficulties, she sees how to chip in." So I wanted to share this quote because it illustrates how one adolescent experienced support from school staff. The quote is from an 18-year-old female who was in care and perinatally infected. And she said, "The nurse used to help me a lot. She is the one who kept my drugs. She gave me one of the keys. So when time comes, I just go, open the cupboard and take my drugs and come back to class. And in case I forget, she comes around the class and calls me outside to find out why I have not taken the drugs. With the principal, there was a time I became ill when we were nearing exams, and she gave me permission to go for treatment at home." Excuse me. We analyzed the data. The experiences of pregnant and parenting adolescents was particularly concerning. This prompted us to do a sub-study of this group. The sample for that sub-study included 9 adolescents who were pregnant at the time or had been pregnant previously, and 1 male who had fathered a child. We also included data from 4 caregivers and 15 healthcare providers. Among the adolescents, 4 were not in care, 5 were in care, but most had delayed enrollment in care, and 3 had experienced infant deaths. None of the 9 reported having an infant infected with HIV, but none had had their infants tested for HIV, and none of the children were receiving pediatric HIV prevention care or treatment. In this group of pregnant and parenting adolescents is where we saw magnified levels of psychosocial distress, particularly among those who had no support. It was very common for these adolescents to find out they were pregnant and HIV infected at the same time. Participants described being fearful, in shock, and in denial. This denial led some to test multiple times before they believed their results. They also described not disclosing their status to key family members because of fear and also because of denial, especially those who tested alone. And then we found that this lack of disclosure delayed enrollment in care. In situations where home-based testing was done with family members present in the vicinity of the home, or clinic-based testing with family members escorting the adolescent, we felt there was a missed opportunity to conduct facilitated disclosure and to leverage support from family members to encourage linkage to care. So the quote on the following slide is an example of this. This quote is from the mother of a 15-year-old pregnant adolescent, and she said, "She was tested by the people who were walking from door to door," referring to home-based testing, "but she did not tell me that she had the disease. I did not even know that she was pregnant. He," meaning the HIV testing counselor, "never told me anything about the illness. If the mother does not know, there is no way she can tell the adolescent to go for drugs." Now I'd like to turn to the previous R01 that also informed the current R21. Around the time we wrote the proposal, researchers were hesitant to include adolescents in studies with HIV testing and disclosure of results. Many had ethical concerns about the risks of disclosing an HIV diagnosis to an adolescent. There were real fears at that time about stigma and the possibility of family violence. So for the R01, we wanted to examine whether there were indeed risks and also whether there were any benefits of disclosing HIV test results to adolescents in a research context, specifically in a research context. For that study, we had 3 specific aims, but I'm only showing 2 because they are most relevant for this presentation. Aim 1 examined effects of HIV testing and disclosure on adolescent behavior and well-being. For this aim, we conducted an observational cohort study with embedded experimental components where we randomized village clusters to receive HIV testing at home or at clinic. Aim 2 was to examine 3 ethics-related concepts which are important for the responsible conduct of research. And these are recruitment, informed consent, and compensation for study participation. And for this aim, we used focus groups and qualitative interviews. The third aim was to develop recommendations for the responsible conduct of HIV research with adolescents. In the interest of time, I'm only going to focus on findings from the arrow 1 that are relevant for the presentation. So the findings that I wanted to discuss today were included in these 2 papers, which were published by our team. And to begin, during the formative phase for the arrow 1, we conducted focus groups with youth, parents, and service providers who worked with youth, such as teachers, healthcare providers, and staff from youth-oriented community-based organizations. We then used the data to finalize the study, design, and protocols for the main study. Most relevant for this presentation are findings from the focus groups we conducted with the adolescents. We did 8 focus groups with a total of 40 adolescents aged 15 to 19, and included adolescents who were not living with HIV and adolescents living with HIV. We explored several topics during the focus groups. As I said, we were looking at recruitment, informed consent, and compensation for study participation. But we also asked about perceptions about parent presence during HIV testing and disclosure of results in the context of a research study. The main reason why we were exploring this question was because the national guidelines for HIV testing at the time recommended that parents should be present during testing and disclosure. However, there was growing sentiment in the literature that this was a deterrent for youth. But what we found in our study was that the adolescents were overwhelmingly in favor of parents being present during testing and disclosure, because support from parents is needed if found to be infected. Only 1 adolescent living with HIV was opposed to the idea. So these 2 quotes are examples of perspectives from youth living with HIV about parent involvement during HIV testing and disclosure of results. An adolescent, so the first is from a male who said, an adolescent you can't trust with decisions. He may make wrong or right decisions. He may say this is the end of life and he's going to hang himself. What if he was there with the parents? A parent always wants the best for his or her child. He will take him for the drugs and take care of him. So there is need for the parent to be there for the disclosure of the results. The second is from a female, and she said, I think she, meaning the parent, should be there because no one was born alone. There is a time you will still need others. So she should be included even during the results. For aim 1, the observational cohort, we conducted surveys at 3 time points, at baseline, at 2 months and 12 months after baseline. The surveys included 2 items about suicidal ideation. We trained our staff to perform suicide risk assessments on adolescents who indicated suicidal ideation, and when appropriate, to engage a supportive adult in the conversation with permission from the adolescent, and to provide referrals when applicable and realistically available. The assessment involved an in-person interview using a script we developed for the study. At baseline, we completed assessments with 652 out of 4,084 adolescents who responded to the 2 suicidal ideation items. Of these, 383 were female, and of these, 55, or approximately 14%, were pregnant. During the suicide risk assessments, 7 females who were assessed as moderate to high risk described pregnancy as a risk factor for their suicidal ideation. Data from the in-person interviews suggested a temporal relationship between pregnancy and suicidal ideation, with periods just after they found out they were pregnant and when they had to drop out of school as highly distressing, in part because of family conflict. Eventually, though, the family tension subsided, in some cases later in pregnancy, and in other cases after delivery. One of the participants gave this account. My mother kept yelling at me and telling me that she can throw me out of her house. I had nowhere to go and decided to take Jik. Jik is a household detergent which contains bleach. My mother took me to hospital and spoke with me. When the child was born, my mother turned me into a prisoner. I could not go out or even spend more than 5 minutes in the shop. It reached a point that I escaped from home and stayed with my friend. My uncle told them that they have to accept me and the baby. My mother is staying with the baby and my father is paying my school fees. I am staying with my grandmother and she is very supportive and understanding. So to summarize our key findings from the previous R21 and R01, stigma, undisclosed HIV status, and lack of social support were key barriers to engagement in HIV and PMTCT services. Sexually active adolescents often found out their HIV and pregnancy diagnosis at the same time. Disclosure of pregnancy and HIV status to parents was delayed due to fear of their reactions. Fear of parent reaction may indeed be warranted because, because family tensions and conflict often followed the disclosure, but we saw that they eventually subsided. And then we found that adolescents feel that caregivers are a key source of support. So we went with this into our the current R21. So in our review of the literature as we were preparing for the current R21, we found that others were publishing similar findings to ours. We saw that there was a growing number of reports from quantitative studies that indicated that pregnant and postpartum youth were less likely than adults to adhere to PMTCT tenets. For example, a study in Kenya found lower rates of ART use among adolescent mothers and among infants of adolescent mothers. Another study found higher rates of perinatal transmission among adolescent mothers compared to adult mothers. So given these findings, we wondered whether and how we could use a digital intervention to reduce the negative effects of HIV and pregnancy stigma among unmarried pregnant adolescents living with HIV. We wondered whether a digital tool could be used to improve communication skills, both for pregnant adolescents and their caregivers, and thereby improve disclosure and enhance social support. The ultimate goal being to improve engagement in PMTCT services and also to improve health outcomes among pregnant adolescents and their infants. Previous studies among young MSM in the US and younger adolescents in Kenya that went further than SMS and WhatsApp messaging had promising findings suggesting that digital interventions may improve HIV prevention, disclosure, treatment adherence, and communication with parents. However, the approach had not been explored among pregnant adolescents living with HIV. So we have two specific aims for our R21. The first is to develop and evaluate a digital intervention to increase stigma awareness, improve disclosure, and enhance enlistment of family caregivers as social support allies. The second is to identify complementary approaches that would be acceptable for family caregivers. For the presentation, I will only focus on aim 1. So for aim 1, we plan to conduct 3 phases. Phase 1 involves individual in-depth interviews with pregnant and married adolescents living with HIV, and then joint interviews with pairs of pregnant adolescents living with HIV and their caregivers. These data will be used to develop a prototype of the intervention, which we will present to another set of pregnant adolescents in focus groups to obtain their feedback. And this we will do in phase 2. We will then use the focus group data to refine and finalize the digital intervention, and then do a small pilot study to examine feasibility of the intervention in phase 3. So data collection for phase 1 is complete, and we are now analyzing the data and working with our partners to develop the intervention prototype. In total, we conducted 22 individual in-depth interviews and 24 dyadic or joint interviews. For the individual interviews, we had hoped to recruit adolescents with different disclosure situations and levels of engagement in care, but we were not very successful. For example, majority of adolescents in the individual interviews had disclosed both their HIV and pregnancy conditions to their caregivers, with only 3 having disclosed one or the other, and 1 having disclosed none. For the joint interviews, to avoid risks of harm to adolescents, only those who had disclosed both conditions were included. Also, we were only able to recruit 4 adolescents who were not enrolled in care or who were non-compliant. And this is actually a good thing because it speaks to the effort that Kenya has put into ensuring that individuals who are HIV infected are receiving care. So in terms of HIV acquisition, we were more successful in recruiting the 2 major groups of adolescents of interest to us, and that is those who had acquired HIV perinatally, as well as those who were sexually infected. So when Theo and I discussed my doing this talk, it was back in the spring, and I thought we would be further along with the study. But as fieldwork goes, we've had a number of setbacks and delays, and so we are still doing our data analysis now. But I was able to pull together some very preliminary findings that I can share. So first, stigma related to HIV was less often reported than stigma related to pregnancy. Pregnancy-related stigma experiences were included not wanting to go to school because of shame and fear of ridicule by peers, gossip by some family and community members, and then some accounts of discriminatory behavior by caregivers and poor treatment by healthcare providers. But interview data suggests that stigma related to HIV is worse than stigma related to pregnancy. Here are some examples of perspectives that we got from some adolescents. In the first quote, a 19-year-old pregnant adolescent living with HIV describes why she thinks stigma related to HIV is worse than that related to pregnancy. She said, because one has to live with HIV all their life, and those stigmatizing them will be around during all that time. But for pregnancy, it's only for the 9 months, then you'll have your baby. Similarly, in the second quote, a 15-year-old points to the transitory nature of pregnancy as the defining difference, making pregnancy less problematic concerning stigma relative to HIV. The participant said, with pregnancy, you can deliver, and they, meaning your friends or your family, etc., still go back to liking you. So the last quote is from a 17-year-old who seems not to have addressed the stigma component of the question. Instead, she compares HIV and pregnancy by what consequences each might have for her education. We included this quote because the potential negative consequences for for education due to pregnancy was a common and important theme to emerge during both the IDIs, the individual interviews, and the joint interviews. And this links closely with disclosure concerns and decisions regarding pregnancy disclosure. The participant said, because for HIV, one can take drugs and keep living their lives normally. But for pregnancy, one's education will have been tampered with. So regarding social support, most interviewees said they currently received adequate support from their caregivers, for example, food and clothing, when caregivers had the means to support. There were cases where adolescents described not having enough food for the household and all would go hungry. But in most of these cases, the interviewees still considered their caregivers to provide them with all the support they needed. More uncertainty surrounded who and or how support would be provided for the child during and after birth. However, most interviewees reported planning to rely on a program called Linda Mama to cover birthing costs. So in Swahili, Linda means to protect. And so Linda Mama means protect the mother. The Linda Mama program was established by the Kenya government to provide expectant mothers with free healthcare to cover birth costs. Additionally, as we saw on the previous slide, how to continue education or how to return to education were high priority concerns for both adolescents and caregivers. This suggests that in addition to birth plans, it may also be appropriate to encourage adolescents and caregivers to consider and set education plans as well. So regarding disclosure, the data are less straightforward, a little bit more complicated to make sense of, but we are working through that data with our Kenya team and trying to make sense of it. What we are seeing are that the more common methods of disclosure are direct disclosure by the adolescent to the caregiver, and what we are calling indirect disclosure, which especially pertains to pregnancy, where the adolescent intentionally waits for the caregiver to find out on their own about the pregnancy. We are also seeing other methods such as authorized and unauthorized mediated disclosure, accidental disclosure when a caregiver discovers clinic cards or ARVs, cases where the caregiver suspects the adolescent is pregnant, but the adolescent is unaware or in denial, and the caregiver sends or escorts the adolescent to the clinic to test. And finally, instances where the caregiver knows or suspects, but waits for the adolescent to find out on their own. So during the interviews, we asked participants about the types of information they would like the digital intervention to address. The most common request was for HIV information, specifically how to live with HIV, self-care, drug adherence, and how to prevent perinatal transmission. Another common request was for information about pregnancy and baby care. Although less frequent, participants also expressed interest in information on how to cope with or avoid stigma, how to disclose their status to caregivers and others, and how to handle partners who refuse to acknowledge pregnancy. So describing their thoughts and ideas about a digital intervention was difficult for participants, in part because most had no experience with smartphones or the internet, which was a little bit of a surprise because prior to going into the field, the literature we had been reading had suggested there was more widespread use of smartphones than we actually found. Still, we were able to get some information that we plan to use in developing the intervention. For example, we asked participants who they would like to convey information in the intervention. So we described to participants the case of a digital intervention where they had somebody in a video conveying information to them. And so we asked who would they want that person to be. And so most responded that it should be a healthcare provider. But the next common response was for a peer who has had similar experiences. When we asked about different intervention features, most participants preferred the use of videos, although surprisingly, quite a number suggested having text-based information. But there were also some who said both would be equally effective. Participants were in favor of brief sessions or modules. They felt that music would be good to use, that there should be some humor. They talked about using pictures and pleasing colors. They also recommended that the intervention should be fun to use and that the intervention should give opportunities to practice, especially disclosure. So the next steps, we are still in the process of analyzing the data, as I said. So we will be seeking to finalize that data analysis. And then as we are working through the data, we are also developing a prototype with our digital intervention partner. And then we will be hopefully conducting focus groups early next year for phase 2, after which we will finalize the digital intervention and then do our small pilot study. So that brings us to the end of my presentation, and I'd like to once again thank you all for attending, and to many Theo and Dr. Remien and Stephen as well.
Thanks so much, Winnie. That was a wonderful presentation. We will jump into the Q&A portion. A reminder to everyone, if you have a question, you can enter it in the chat and I'll read it out on your behalf, or you can raise your hand and I will unmute you.
Thanks so much for the presentation. I think you confront us with your data and your findings with a world that is not so familiar for everyone over here. So it's really good to learn about these experiences. I was wondering whether you could share a little bit about the prototype that you're developing and how that process will be and how you will integrate your findings into the development. And of course, I understand this is all preliminary because it's ongoing, but it would be interesting to learn a little bit more about that.
Yeah, sure. Yeah. So, one of the things going into the proposal stage, at the proposal stage when we applied for the funding, in our minds, we thought that what we would be developing is something that would be used on phones, smartphones, individually owned. But having gone into the field and finding that actually access to smartphones is not as widespread as we thought it would be, we've sort of changed tack. And so now what we are exploring is the use of tablets. The other thing that we found, it's coming through in the data, is that many of the adolescents go to the clinic, they suspect they're pregnant, or they suspect, or the parent suspects that they're pregnant and encourages them to go to the clinic to be tested. And so that is when they discover. So the adolescents might miss their periods and feel, maybe I'm pregnant. So they go in and that's where they discover that they are pregnant. So we felt that maybe the clinic is the best place to have the intervention be situated. And so have tablets available at the clinic. So that's one change that we had to make. In terms of the intervention, what we are thinking of is having a modular type of intervention where we would tackle different topics within different modules. And we would expect the adolescents to go through the modules in a linear fashion. What we are challenged with now is, so given that not only is it that smartphones are not widely used, but access to internet is also not as robust as we would have thought. So the question then is, how do we build the intervention so that it doesn't take up too much bandwidth to download information, even if it's being done at the clinic? And so we are exploring with our partners now a mixture of very brief videos with infographics and probably some cartoon, comic book style infographics that we will incorporate throughout the intervention.
Thank you. If there are no other questions, Stephen. There is a question. Okay, I'll shut up.
Phil, go ahead.
Yeah, hi. I'm Phil Kroniski at the HIV Center, and yeah, very interested in your work. Wonderful presentation. So many overlaps with things that I'm interested in and studying. My work is primarily in Uganda, and also I work in the US. So one of the, I'll just say a few quick comments. One is, it's really interesting to see the associations with pregnancy and attempted or suicidal ideation, and that just we had found that among adolescents, and we had, Dr. Claude Mellons and I and the CASA team have a recent analysis that found a similar association in a group of adolescents living with, or young adults living with HIV in the US, but we hadn't seen it in the literature anywhere else. So it's exciting to see that. I mean, also disturbing, but so I was curious, maybe I missed it, but if you had, what are the potential, interventions that are available in Kenya, or what are the next steps on that? And then I also have a lot of ideas. Maybe we can talk offline if you're interested about how you could deliver somewhat like a pared down intervention that you're talking about without smartphones, because in Uganda, similar circumstances, most adolescents do not have smartphones, but they have button phones, or what we call flip phones. And we've designed an intervention to link adolescents to care using interactive text messaging. I know it's much less exciting, but it can work. So happy to talk about that if that's of interest.
Yeah, I would really be interested to talk with you, Philip. I'm really excited to hear that, because so I do know that there's some movement into mobile mental health space, and I think there has been some focus on adolescents. Not much. I think there's a lot more being done in the adult space, but really after after the R01 findings, one of the areas that I really wanted to move into is developing interventions for mental health for pregnant adolescents, because that really is a huge gap. And so I'm really interested to hear what the ideas that you have, because the idea of the pregnant adolescents, getting them into care and so on, was sort of my first step into that. And then I was hoping to then follow that with mental health related studies. So yeah, I would really be interested in talking more with you about that and exploring ideas.
Great. Yeah, thank you. I'll look forward to connecting with you.
Yes.
Thanks, Phil. Teo, did you want to ask your second question?
Yeah, Winnie. So you're changing your ideas about what the best way is of reaching the people, but whatever you ended up with is something where the youth is already in the clinic. So there is already a connection with them, and they're there in person. And I was wondering, you must have thought about why not do an in-person interaction with them, or why not do something in print? Why go for technology?
Mm-hmm. Yeah. So why go for technology? So there was a little bit more that didn't get into so my first idea around addressing this issue of stigma, disclosure, and social support was to have a visiting nurse come to the homes of the adolescents to help with facilitated disclosure, and to work with the adolescent and the caregivers to build their communication skills, and then to strengthen their relationships, and thereby promote better engagement in care. That was not well received by the NIH reviewers. I tried many different ways to do that, but the feeling about that particular intervention was that it would be too expensive. It would be too costly. A lot of people have used community health workers, to do a lot of the work that nurses are doing. But in our study, so as part of the R21, we had two of our staff were nurses with bachelor's degrees. And so at the end of the interviews, they would then help the adolescent and the caregiver to, to come to some, resolution, so that they escorted some of the adolescents to the clinic to enroll in care. So that is why we thought it would be better to have a nurse trained as opposed to a community health worker, because they have training, a more robust training, counseling, engaging difficult conversations and things like that. So that not having worked, it was only then, as I was beginning to look at the literature, that this idea of the digital intervention came in. And the reason I gravitated towards it is because youth seem to have a difficulty communicating with folks, adults, in, either the healthcare providers, teachers, they might see them as support, but even if you've done interviews with adolescents, it's like pulling teeth, getting them to say what, to answer the questions. And so I thought maybe a digital intervention might be more accepted by the youth than face-to-face. Now, when it comes to why not print, there have been different attempts made to have, not only print, but media bursts of information in the radio and little prints of information disseminated in communities, but those have never been evaluated. And I wasn't sure that that would be an effective way to reach the goals of what we were aiming for.
Thank you.
Mm-hmm.
Thanks, Teo. Any other questions for Dr. Luseno? If not, Bob, I'll turn it back to you.
Okay, thank you. Thank you, Stephen. Thank you, Dr. Luseno. That really was very interesting, and I'm glad you had the interaction and questions and discussion, that people spoke up, and you and Phil can connect, and maybe with others as well. So thank you for being here. Thank you everyone for joining us today. We look forward to seeing many of you in person and others on Zoom for next week on Thursday for the Biobehavioral Seminar Symposium for that day. And I know Stephen had put the registration in the chat if you had not already registered. And then again on September 22nd, we have a double billing of our former postdoctoral fellows. So we look forward to seeing you. Have a good week. Take care, everyone, and bye-bye.